continue to keep attention till now, especially distinguished guest. Now I will introduce the next speaker, Dr. Fang Hsiu-Yu. I remember he always give a special, very impressive cases. So now he will share his cases for us. Dr. Fang, please.
Thanks, Chairman. Thanks for your introduction about my case presentation. But today, the topic is our regular case. Our daily practice will encounter the ACS patients. So I will introduce you 2 cases of our daily practice, very simply and very educationally. And this is first case, a 58-year-old male with diabetes and smoking, presented with chest pain at midnight, acute anterior ST elevation myocardial infarction. This is his EKG. And this is his RCA baseline coronary angiogram. You can see from the proximal to mid RCA have some tendon 50-60% lesion. And this is the left side coronary artery and the total occlusion from the osteo of LAD and with heavy thrombus burden. And of course, we do this STEMI case with a thrombus suction from eliminate. And after that, reperfusion, we can see that the lesion is almost at the osteo of LAD from proximal with the bifurcation lesion at diagonal. And this is a Medina 111 lesion. So at this point, we decide to protect the side branch first. So we do the diagonal branch pre-dilatation with the mini track 2.0 up to 4 to 8 atmosphere and 16 back when the balloon is back to the LAD. And we also did the balloon dilatation of LAD with the Hsiu-Yu balloon 3.0. This is the OCT after the balloon dilatation before the stent deployment. You can see that from the thrombus burden heavy portion, and this is vulnerable plaque, and this is a heavy plaque burden from here, and this is almost at the lemon. So next slide, you can see that the lesion with heavy thrombus burden. So at this point, I would like to ask you the question, if in financially okay, the patient said everything is okay, will you put a BVS in a STEMI case? In current situation, like the less evidence-based situation, please. Okay, about 70% in the BVS is financially okay. So that's our today's purpose. And at this case, what bifurcation strategy will you prefer? The first choice is 1DS plus crossover only. And the other choice is 1 BVS and crossover, or hybrid bifurcation, including BVS and the DS, or 1 DS only, leave the diagonal alone, or 1 BVS only, leave the diagonal alone. What's your selection? Okay, totally agree with this conclusion. So this is our next. We have pre-dilated with the diagonal first. So now we are pre-position of the BVS stent, and we decided to put the BVS from the lesion to near the osteo, just osteo, or somewhat a little bit protruding, and with BVS 3.0 28. And after that, we use the filter FC wire cross over the diagonal branch with the snuggling technique, with hug technique, with the Hsiu-Yu 3.0 and the mini track 2.0 up to 8 atmosphere simultaneously. And this is the final angiogram. And you can see that the LAD from the osteo to the distal is very good, but somewhat the diagonal have some dissection plaque. So after the angiogram, we can see the OCT after that. Remember, this is midnight in the when we are calling out for the STEMI patient, we do OCT for him. This is near the lemon or LED osteo, we can see some a little bit some malopposition, but in the LED hole, the stent struct, the BVS have placed very well, and you can see also that this is the point of the diagonal branch, and we open it, the stent struct at here. So finally, we close the case at midnight. So we go on to the case number 2. This is also a 56-year-old male with hypertension, hyperlipidemia, smoking, presented with non-STEMI, and his EKG is also fine. And this is his baseline coronary angiogram of RCA. We can see the pedal branch subtotal occlusion and the PDA with tubular 80-90% stenosis. And this is his LAD with proximal have 80% calcified lesion and distal LAD subtotal occlusion. And OM branch also have 70% stenosis. So our step is do the PCI to LAD first. This is a culprit lesion, but the smallest balloon with the mini track 1.2 cannot pass even under the anchoring balloon technique. And but we didn't do that like the previous speaker, the balloon festival. We have another choice. We did directly to the rotational atherectomy for the LAD from the 1.25 burr to the distal LAD, and we changed to 1.5 burr to the proximal LAD. After the debulking therapy, we do the balloon dilatation with mini track 2.0, 2.5, and here 3.5 for the proximal portion. And after the balloon dilatation, we do the IVUS OCT to do the stent size evaluation. Okay, this is the IVUS. We introduced the IVUS catheters to very, very distal LAD because we decided to put the stent maybe from the distal, very distal LAD bifurcation here. So we need to know that the stent, the vessel size of this portion is. So we do the IVUS first, but in IVUS we can see the very distal LAD showed diffuse disease and only have a 2 vessel diameter at this portion. And at this portion is much better, increase up to 2.5 or 2.75. And this is the IVUS from mid-LAD to the proximal LAD. You can see that very calcified lesion after atherectomy, and mid to LAD to proximal LAD up to 3.0 or even bigger diameter. So in the third question is, in this case, what kind of stent strategy you prefer? That maybe the first choice is 3 DES from the very distal LAD to the osteo, near osteo LAD, or 1 BVS, 2 DS, or 2 BVS, 1 DS. Please make some selection. This is totally different with our. So everybody select for the 1 DS or 2 VVS. Okay, change back to my slide, please. This is what we think about it. So we decided to put a Zeiss Prime 2.25, 28 at distal LAD, and mid LAD with BVS absorb 3.0, 28, and the proximal LAD with 3.0, 18 at the near osteo. And after that, we do, of course, the post-dilatation with the NC track balloon. And you can see the final LAD showed very good result. And also we check with the OCT finally. In this portion, we can see that this is a distal LAD, the 2.25 DES. And this is also the DES. Okay. And this is mid LAD to proximal LAD. Of course, we can see that the image from the distal, very distal, we have DES only for the 2.25 Zeiss 28. And at the overlap DES, BVS portion, you can see that this is one layer DES and one layer BVS overlapping. And from the mid to proximal and to osteo LAD, it shows good stand well positioned, finally. So after that, we did also the circ with the balloon predilatation and the IVUS to show that the circ vessel diameter, and put another BVS 2528 at the OM branch. And also we did the RCA with mini track and Hsiu-Yu 2530 dilatation, and the IVUS of PO branch show the much smaller vessel diameter, and the IVUS of the PDA show much larger, about 30 diameter. So we put the two BVS 2528 at PO branch and the 3028 at PDA. So this is the final RCA. So our cases only reveal that our daily practice of acute coronary syndrome, like STEMI and non-STEMI. So my question is, maybe I'm the final case presenter, but no one is asking about this question. I want to ask everybody about this case. According to Patrick Saray's 2010 circulation, the publication, the dual-plated in absorb BVS trial, they're only 6 months. But in our case, when we encounter that acute coronary syndrome, like this case, how long the dual-plated will you give? 6 months, 9 months as insurance control, or 12 months, or more than 12 months? Please, selection. Okay, this is maybe everybody's choice. Okay, so let me check back. Okay, so my lessons from my cases is why BVS in our STEMI patient, because they are very frequently young, less extensive CAD, and may live many years in the future, and does not preclude future surgical revascularization options. And in case with much calcified vessel, debulking therapy first must be done before the absorb BVS implantation due to its thicker struct and the closing profile. And hybrid stent strategies may be feasible, especially when small vessel caliber in the distal portion, and dual plate therapy for at least 12 months before new evidence released. Thanks for your attention.